Welcome, everyone, to Here's What I Really Think About These Oral Appliances, an expert panel discussion. I want to thank all of you for being here. I know there's a trillion other things you could be doing on a Tuesday evening, and the fact that you're so committed to your patients, your practices, and your profession that you've opted to spend it with us so that you can glean some insights from this panel of experts is truly commendable. And I want to thank you. Speaking of the panel of experts, let's introduce each of them. First, we have my good friend, Dr. Dave Federici from the great state of New Jersey, in air quotes, great state. Uh, Dave Federici, tell them who you are and why you're on the panel tonight.
Well, thanks for having me. Love to share experience. 1992 graduate of University of Pittsburgh School of Dental Medicine. I know Nicole lives in my hometown there in Pittsburgh, so it's nice to be on with her. Just basically committed a lot to the American Academy of Dental Sleep Medicine for the last bunch of years. Faculty, in my state, we just held a New Jersey Sleep Society symposium on the board of. Like to publish, write little things here and there, and corporate initiatives as well. So this is my space where I love to be. So thanks for having me.
Thanks for being here, Dave. And then next, we have one of my dental sleep BFFs, Dr. Nicole Chenay. Dr. Chenay, you, as Dr. Dave mentioned, from Pittsburgh, and I think you just got a mani-pedi yesterday. What else do these people need to know about you?
I took 5 minutes for myself yesterday. Yes, I did, Jason. Thank you for having me. I'm the president and owner of Sleep Apnea Dental Centers here in Pittsburgh. We have a few locations. I have an associate, Dr. Paige Muir, and exciting news, we're adding another associate, Dr. Kimberly Klein. I've been in this space in the dental sleep medicine world as long as Jason, for about 15 years, and that's why he's one of my BFFs. And just excited to be here and excited to share.
Is this how you do it? Is that the heart thing? Am I doing it right?
Yep.
Okay. Well, thanks for being here, Dr. Chenay. Dancer extraordinaire, Dr. Suzanne Tai, who was kind enough to step in step in for Dr. John Carollo. He was unable to make it tonight. He had some health issues. He's on the mend. Everything will be fine. And who's the only person that could fill Dr. Carollo's shoes but Dr. Suzanne Tai? Now, you might be wondering, why don't you have a professional headshot of Dr. Suzanne Tai? We do, but we replaced it with her smiling face holding up her brand new. What did you just get brand new, Dr. Tai?
The letter that I am now a diplomat of the American Board of Dental Sleep Medicine. So, yay, we just found out.
3 of them on the panel tonight. Congratulations.
Thank you so much. I'm so happy to be a part of this group. Thank you so much, Jason, for inviting me. My heart and my well wishes go out to John. But for me, I'm just really honored to be on this panel with such amazing people here on this panel. But for me, I've been practicing dental sleep medicine since 2017. I own a dental practice. I own 2 sleep practices. I just opened the second one 2 weeks ago. So super excited about that. And, I practice sleep and sleep only. So I'm just happy to be here and happy to share whatever knowledge I can to help the attendees.
Well, thank you so much. And thank you to each of you for being here. I mean, you have very busy schedules. Dr. Chenay, I know you've got a birthday party this weekend. You've got a 50th anniversary party this weekend. The fact that you're here sharing your knowledge and wisdom experience is incredibly, we're incredibly appreciative. I speak for all the attendees. Thank you. Before we dive into the questions that were submitted by so many of you attendees out there, just a quick housekeeping thing. You can type your questions down in the chat. We'll try to get to all of them tonight. So submit those. We'll try to answer them in line as we go. Also, if you stay on until the end, we end at 1/4 tonight. You will receive your CE certificate via email in the next 48 hours. That means sometime by Thursday evening. So please don't email me tomorrow morning telling me that you haven't received your CE certificate. 48 hours. You'll probably receive it much sooner. If you don't have it by Thursday evening, on Friday, shoot me an email and we'll ensure that you get it. Otherwise, you'll get it via email in the next 48 hours, one more time. With that said, thank you again, everybody, for being here. And let's dive into les questions. Elias. All right. There were a lot of questions about this. Actually, you know, we've done topics related to appliances many, many times. And there were more questions about this time than ever before. But what are the considerations for using some of the most common appliances or materials? So nylon, PMMA, acrylic. If we could start maybe with you, Dr. Federici. When do you use one versus another? What's a pro con of each?
Well, I usually take multifactorial considerations of the patient's needs. You know, the amount of teeth they have, the strength of the teeth, the height of the teeth. Am I going to have retention? Do we need to modify it for future dental work? Do we need something that's PDAC approved? So there's multiple reasons why you might choose a specific. You know, historically, in my earlier days, I used to try to fit every patient into a type of an appliance. Now I customize the appliance to meet the patient's needs. So those vary patient to patient. And some of the factors in consideration are, when I do an exam, is just the patient themselves. Do they have proper vision? Do they have arthritic fingers? Do they have cognitive issues? Visual issues, where if we're asking to change a strap or they live by themselves, we have to look at the possible physical limitations of the patients for titration. Do they come from distance? So there's many factors that go into the type of appliance, and then the type of appliance dictates which one of these criteria, whether it's nylon or PMMA or acrylic, may best serve the purpose for the patient, not just me, or specific cost needs, things of that nature.
Sure. Totally makes sense. What about you, Dr. Shanae? What do you have to offer regarding the different materials and why you might prefer one versus another, or what the indications, contraindications are for each one?
Well, I agree with Dave in the fact that you're thinking about everything during that exam. To dive a little deeper, like if we have people on the webinar here who are like, I have no idea what to use, I'm new to this, I'd break it down this way. First of all, we have, MG6, we have medical grade material too, which is different than all of these, which is in Prosomnus. I lean towards that one quite a bit now because we can customize it so much. But that's if you're doing digital scanning as well, where you have a lot of accuracy and a lot of attention to detail. Historically, I've gone through all of these appliances because I've been, doing this for 15 years. So obviously we started with acrylic devices. The great thing about acrylic devices is that you can get ball clasped inside of the device. So you have a person who has a lot of crowns and dental work, maybe an older patient with some bone loss. The great thing about that traditional acrylic device is you can adjust those easily. If they come loose, they can come into the office, use a little lab knife. You tighten up those little ball clasps, you can adjust that easily. They get a new crown, no big deal. You go in the lab, you adjust it, it's fine. What are the disadvantages? They tend to be bulkier. I mean, they are dental acrylics. They tend to have a lot of metal parts to them. Like Dave said, you have to think about the older patient and how do they manipulate the advancement tools on, say, a Herbst arm. It's hard for them to see the hole, or even in any type of dorsal fin, finding that hole with a key. And then the challenge becomes with those is then they get calculus buildup, which is really hard for the patient to keep clean. But they're easy to manipulate, right? So then we move on to the nylons. And we found, as we were moving on in this field, the nylon appliances came about, and we were really excited about these. But you have to use those with caution because of the way they fit on the teeth. Again, if you have a person who has all these veneers or crowns, the way they grip the mouth and the teeth, I wasn't very comfortable with that. So during that time, about 12 or 13 years ago, I would lean towards an acrylic device that I could customize a little bit more and manipulate chair side a lot easier than nylon. But what is nylon great for? Nylon's great for the patient who has a very small mouth, who doesn't want to be overwhelmed with bulky material, who maybe has a gag reflex, who doesn't have a lot of dental work, and that worked nicely. What did I find over time with nylon? With nylon, what I found over time is the way, in my personal experience, the way it kind of put pressure on the arches. I saw some movement and crowding of the lower anteriors at times. I saw a little bit of porosity and staining, which could be a deterrent for the patient.
Let me pause you there for a moment, Dr. Sinead. There's another question we've got coming up in a moment. So I want to save some of that for that question for you to kind of expound further there.
Okay.
If we could go to the next question, there's some questions about which specific device you might recommend for a few different patients, the way that they might present. So let's go with you, Dr. Ty, with maybe a patient that's a really heavy bruxer. Are there a couple of appliances that you might lean toward for a patient that's got signs of extreme wear?
Absolutely. You know, when I'm looking at a heavy bruxer, I want something with lateral play. So I do like the Avant. I do like how there's lateral play in that aspect. I like that the Avant and the Herbst Advanced Elite are PMMA. So their strength is really good. The quality is really good. They don't really break. Even the Presonus Evo can be a really good device for heavy bruxers as well. You can't ask for the lateral wings to kind of move more laterally, and you can ask for metal reinforcement, but those would probably be my top 3 that I use for heavy bruxers. And that's
Okay.
what I would use. Mm-hmm.
What about yourself, Dave? Is there a particular device that you prefer, or a couple devices you prefer for patients with signs of a lot of bruxism?
Yeah, you got to evaluate the TMJ and the muscle complex to go with that. You know, some people actually who are bruxers, if you can actually control them and actually keep them isolated, and it actually could break that bruxing habit they've had historically, because a lot of people brux historically from untreated and undiagnosed sleep apnea. So we have to take that into consideration. But a lot of these appliances out there, you can just ask to make more durable. Like if it's an occlusal surface, if the patients are going to go laterally and we got freedom, you can just have them make the surface a little thicker, maybe open up the vertical and add a millimeter to each plane, each arch per se. So most of the materials and the appliances these days seem to be more durable. Obviously, if you have skinny little wings, say on the dorsal, and there's a really heavy lateral, and patients say that, hey, I sleep on my side a lot. Because, you know, we're opening up vertically, we're moving them horizontally, then they lay on their side, and then if they clench, there's like 4 dimensions where not only is the muscle complex doing, but the appliances are taking those force vectors. So like Suzanne said, if you can have some more play in it, you know, basically break down what type of bruxing a lot of people do. Some people, you can look at their wear fastest and they just go forward, which might guide you to a different type of appliance. So it's all in that initial evaluation, but I've noticed more and more over the years that materials have gotten better. Even the ones historically might have been a little weaker have either can be more modified to make stronger, or they just naturally over time know that if they make a weak appliance, that patients probably won't like it if it breaks, and the the dentist might not be ordering it, so they're pretty cognizant of that.
Dave, what about for a patient like that, adding an anterior point stop or a discluding element? Is that useful? Is that something?
Absolutely. Yeah, especially if you're thinking they're having migraine type of scenarios where you want to get posterior disclusion where there's nothing in occlusion in the back. But you have to watch too if they have ceramic, like Nicole was saying, anterior cosmetic scenarios where all the pressure is going to be on those front 4 teeth. Do we want to risk delaminating a veneer or breaking a ceramic crown? So there's that valuation of the patient's dentition, the bone levels, things of that nature. So you can see how an exam, you really have to look at 25 to 30 things. And sometimes just listening to the patient, if they don't feel cognitively sharp or they're not going to be able to get what you're doing, you're not going to give them what we call a complex type of appliance, right? One that may be very difficult to change or advance themselves or to get in and out or to, just to try to communicate with them. So a lot of these factors come into play when I pick an appliance.
Sure. Dr. Ty, what about for patients that are fully or mostly edentulous? And that's actually a question that just came through right now as well. So is there a device that you prefer for that situation?
The device I love, and I've said this before, I do love the Herbst Advanced Elite for patients who are edentulous, mostly because I do like the B-Flex liner that they provide. It just seems softer, it's comfortable for the patient. The bilateral compression of that Herbst Advanced Elite makes it to where it doesn't dislodge as easy. So that's usually my go-to. You know, some dorsal devices, due to the propulsion mechanisms, can be really good as well, but truly my go-to is the Herbst Advanced Elite. So that's my go-to.
What about Dr. Federici, Dr. Shanae, any device that you prefer for the situation, or whether it's the same?
Go ahead, Nicole.
I personally, I really don't treat fully edentulous patients in my practice. I feel they're best served referring them to one of our sleep ENTs for Inspire therapy at that point. For partially edentulous, I'm with Dr. Suzanne with, you know, a Herbst is very helpful in that situation. And I use a lot of Prosomnus EVO. I mean, those have worked well too. But typically, at least with a Herbst arm, they're able to move around a little bit, and when we're working with a lot less teeth.
Got
So
it. And,
I look at the mechanism where they're missing the teeth. So some appliances have a lower posterior bar attachment and some have a maxillary posterior bar. So you have to see if the hinge, if you have no teeth back there and the appliance requires the hinge to be back there, that's going to be an issue because you're going to be extending that appliance in a edentulous area where there could be some compression on the gum tissue. But I've been very successful to piggyback. So I have patients who have dentures and I'll get a really thin nylon. And if there's no retention on the denture, I actually will cut little grooves in the flange up in the buccal vestibule, and I have the patient pre-snap the appliance onto the denture and then put it in with some good adhesive. Now, it's got to be a good fitting denture, don't get me wrong. So your lower one usually dictates that because the uppers are pretty easy. But if you can get a lower denture that fits pretty well, I've been very successful to piggyback it on that. And also with partials, the patients may only have the anterior 6 teeth. And again, being able to piggyback on top of that. So I guess a good way to test to see if an appliance will work or not is you can send the scans to the labs and say, evaluate this for your appliance. If you don't think you're going to be able to fit this or this, then don't make it. So you can basically shop your scan out to multiple labs. And I do this probably a couple times a month and say, what do you think about this? And I don't want to have to deal with a patient with this thing dislodging. They know me from lecturing at AADSM, but I'm in front of students and they don't want to have me have an issue where, hey, he's not recommending our appliance because, you know, the last 5 of his is dislodged and he's been upset. So if you send the scans out to the patient, to the labs, they can actually put it on their, you know, the computer software and see if their appliance will be successful with it. Because most of the time, they're not going to make an appliance just for an appliance if you're not going to end up being happy and it pops off.
Sure, sure. Dr. Shanae, you mentioned earlier when I think you were talking about the nylon devices being indicated for patients with smaller mouths. Yes.
Yeah, sure.
Yeah.
I mean, that's a great option. Again, somebody who has a tiny mouth, they are very worried about what they're putting into their mouth because it's hard for them to even be in a dental practice and have dental work done. So, I mean, I drive my labs crazy and I say, as small as possible, make it as small as possible. And that doesn't mean just the arch of material around the teeth itself. It means, okay, what about the mechanism? How about where you have ball clasps or whatever it may be to have a rubber band? You know, some devices I think make those, you know, hooks for rubber bands too thick, and I'll kind of get on them about that and say this needs to be smaller because everything matters as far as like lip seal. And you don't want bulk, especially in the anterior, that's going to make the lips come apart and then the patient's going to start mouth breathing. And that's going to create additional problems for the patient.
Sure, sure. What about yourself, Dr. Ty? If you've got a patient that presents with a particularly small, narrow arches, small mouth, is there a device that's your go-to?
Sure. I mean, I do like the Avant. It is small. It seems to be working well with small mouth patients, but then also the nylon is a really good go-to, especially with Medicare type patients who are very frail and small. Their mouths are just so tiny. Luckily, some of the nylon devices are Medicare approved or PDAC approved. And so it works really well for them. Now, I mean, that's really when it comes to the small mouths, it's either the Panthera or the Avant for me. And so I hope it's okay. I'm like naming these, the actual devices.
Actually, that's a great point. Elias, why don't you roll to the next slide? And actually, I'm glad that you're doing that. Something I want to address here real quick. Elias and I invited you to be our panelists because you are electric personalities and you have a ton of experience, and each of you are very open, fortunately for all of us, with sharing your knowledge and experience. We don't have any corporate sponsors for these webinars. And that is by design, because we want you to be able to speak openly, to share your knowledge and experience with these people. So please, as long as you're comfortable sharing, brand names, product names, that's great. Because otherwise, I remember back in the day, maybe the first AADSM Mastery series, when there was so much emphasis on objectivity that people would say things like the white nylon appliance. And at the time there was one, but people would have to then take that information and Google. Hopefully they were resourceful enough to go Google or Bing or whatever people do to try to find out. So you being so open is much appreciated. And we're about to get into a section here where you're going to have no choice. So I'm going to ask you to speak openly, as long as comfortable, as openly as you're comfortable doing, and share whatever insights, indications, contraindications you might have for the following devices. So let's bring up the first one, and we'll start with you, Dr. Ty. That's a Dream Tap from Airway Management, made by a number of different labs around the country. But TAP has been, for many years, TAP was kind of synonymous with oral appliance therapy. And they're down there in your neck of the woods, Dr. Ty, so we'll start with you down there in Dallas. What's your, when do you use a TAP? When do you not use a TAP? What do you love about it, hate about it? What's the skinny on the TAP?
I honestly don't use the TAP very often. I don't. When I did have a TAP, I noticed it was bulkier than some of my others. That's what I noticed. I think for benefit, I think the TAP is really good to use. If you're going to use it for dual therapy, I think that'd be great. It just really isn't my number one device. So I don't know how to really talk too much about it. I don't use it very often.
I appreciate your candor. What about you, Dr. Shanae? Experience with the TAP? Good, bad, ugly?
Well, I had a lot of experience with TAP when we first started practicing. Basically, that's how I got physicians to refer to me, because they insisted on me using a TAP 15 years ago. Have I used a TAP since then? No. What were my experiences with TAP? Well, number one, I'm a big believer in the tongue posturing forward and giving space to the tongue and to the airway. And in my personal experience, the TAP mechanism blocks the tongue. And so what I found with patients is that they would actually advance their lower mandible to these extreme advancement positions to keep getting their tongue out of the airway. Whenever we would change them to a different device design, they wouldn't have to advance their jaw anywhere near as far because their tongue had far more room. I had some experiences with the pressure being far too great on the anterior teeth. They're not meant to take that type of pressure, where the whole advancement pressure is on the anterior teeth and where their front teeth cracked off. Once that happened once and twice, once in particular to my own mom, that kind of changed the game for me. I feel that the forces need to be distributed in other ways.
Okay.
On a positive, I will give a positive. On a positive, you don't need to worry about rubber bands to keep these appliances closed. Some people, that's what they started in. They continue to love it. There was a lot of, down the road kind of issues with these as well. And the other challenge is that the hook would strip as the patient would use any bruxing forces, and it would slide back on the patient.
Right.
You were
Yeah.
sleeping, and then you'd have to replace it, and that seemed to be a continual problem as
Yeah,
well.
I know that was a major issue for some time ago, but I think they've addressed that issue, over the years. But certainly, yeah, I knew of that problem as well. This is the next device is one that we've heard mentioned a few times tonight. That's the Panthera device, a nylon device. Dave, you want to talk a little bit about the
Sure.
pros and cons of the Panthera device?
Yeah, I just wanted to add a few things to the prior because that connected
Sure.
device is something that segues to the previous segment where we said small mouths. You have to think about a two-piece system where a patient could put an upper end first, then a lower end versus a connected device. They have to open up super wide to shoehorn this thing in there. So the tap device, like you said, like Nicole said, it's not giving any space for the tongue, but it's going to be put in there and it's much bulkier, right? But again, it's also great for somebody who doesn't have the dexterity or the vision to add elastics to an appliance. So maybe a more updated, more modern nylon version, that would be the slide appliance, where there's no hardware on the side, which the tap is also nice for. There's no cheek issues because the connection's in the anterior, right? So it's streamlined. But the slide is a nylon version, which is thinner, but you can have an air hole with that one, so it does allow the tongue to come forward too. So that's the occlusal type of slide where the titration is done on the occlusal surface. So you have to have a little bit more occlusal space for that, but I think it improves upon the old tap system. As far as the Panthera, yeah, great product, probably the best all around for PDAC approval. Again, eliminating the metals. Obviously, porosity with the nylon, so you have to stay on top of it. With the cleaning systems, I know some of the denture tablets out there have, sodium perborate. So that's one of the things I always ask for patients is how sensitive are you to allergies, to your tissues? Because if you have a device that needs chemical cleaning versus something, say, like an Evo, where it's a milled device where there's zero porosity, that's just a scrub and soap and water. That might be an advantageous, scenario. This one obviously is very difficult for the patient to self-titrate, right? You have to spin at 270, pop it out. So again, the patient with the dexterity issues, or say you're getting a referral from 80 or 90 minutes away, like I do sometimes, are they going to want to schlep back and forth for the titration with gas, time, and tolls, right? So, but the nice thing about this particular company, they have a backup. So they have like an X3. So if this one doesn't work, it's an option to upgrade to one of their other appliances. And I know you have a question later coming up about if something doesn't work, what do you do? It's nice to have a product or a company that has multiple products in their line. So if one of their products doesn't work, there's something else within the line that they can move you through and work some type of financial benefit for you.
Mm-hmm. Dr. Ty, what's your experience with this device? When do you use it, and when do you stay away from it?
Sure. With the nylon devices, Panthera, I do like it. Again, for ladies who have smaller mouths or just smaller mouths in general, I do like that it is flexible to where someone with an interesting path of draw, where it's hard, their teeth are going in all different directions, it can have some flex to it. And so even if you warm it, it has a little bit of flex, so it's easier to kind of come in and out. I think it's a great device. Again, for PDAC approval, it's fantastic. I will say it does stain, because of the porosity. So I see the staining. I just warn the patient. I truly feel like with all of these devices, if we know our verbiage and we know how to warn the patient ahead of time, and they're aware and they know that they're choosing an oral device over CPAP or other treatment options and discussing all the benefits and effects of each, in the end, I don't have too many patients who are just upset by whatever can happen with these devices. So they're all really good. But yes, as far as the Panthera is concerned, it's usually smaller mouths, PDAC approval, and path of draw that I look at.
Okay. And just to I'm sure most on here know this, but when you're talking about PDAC approval, that's a term we've heard mentioned a few times tonight. You're talking about for Medicare patients. It's approved to be used with Medicare patients. Yes. Dr. Shanae, you mentioned this device a couple times tonight, or it's been mentioned a couple times tonight. This is a Herbst. That particular one, I think, is from Dynaflex. Multiple companies make them. ProSomnus makes one. Somnamid makes one. Apex, many labs offer Herbst devices. When do you use a Herbst? When do you decide to go with a Herbst versus other devices that are out there?
Plain and simple, if they need a PDAC approved appliance. I mean, now we have so much technology and we have so many options. Really the only time I'm leaning towards a Herbst, other than, you know, like I said earlier, the patient who's missing multiple teeth, and depending on where those teeth are missing, where we just need to have a connection upper to lower. That's mainly the only reason why I'm using a Herbst. But it is a workhorse. It has been a workhorse for many years. And the thing you can request from the labs is that you can have them make it as minimally bulky as possible, depending on how many teeth you have to work with, and requesting those specifics.
Got it. And Dave, you know, you being associated with the ADSM, I'm assuming if anybody's in the know on this panel, it's you. You know, is there going, when is there going to be a change to those PDAC guidelines, because some of them seem rather antiquated and
Yes,
sort of
we're hoping sooner rather than later. You're
Yeah.
right, with K1027 being adopted and some technologies, and of course we still have this other big elephant coming up to us as far as Medicare. So you know, we would hope that you know, it was always about durability initially, right? Fixed metal, it's going to last supposedly for the patient, and you know, most have a 3-year warranty, yet they only pay for replacements every 5 years. I know you know, some of them is up there to 5 years to match that, but between years 3 and 5, those seniors aren't protected. And I know the Panthera has a 5-year. So if it's about warranty, we need to throw that out the window and take the handcuffs off of us and say, hey, reimburse us the same amount. Let us and the patient, you know, dictate what's best for the patient. You can still reimburse us the same amount, and we'll have the discussion if they would like to upgrade. But by purely not paying for an appliance just because it's not on that list doesn't solve anybody's problem, really, because it's the same amount of outlays. We all know we're all doing these workarounds with these, and patients are doing, you know, multiple appliances, and it's just waste. And I think if at some point, you know, it is the government's going to take a little time, but I'm hoping 25 is the movement year for on a lot of things with Medicare.
Yeah. What about, so you mentioned workarounds. You know, we don't have it featured here. There weren't any questions about it, but I mean, what's up with the snore hook and workarounds related to that? Nicole, you have any, and Dr. Shanae, you have anything to?
I'm going to strongly recommend to everybody that's on this webinar, you need to stop the workarounds today. You know, it's been lectured upon, you know, many of my colleagues have felt like, hey, you know, let's give a patient, say, a PDAC approved appliance, but let's also give them what they really want, you know, and oh, well, we have our forms and an ABN form, etc. But I know for a fact that Medicare is cracking down on this. And I would suggest that the craziest thing is that we think that we're providing both, and then that's an okay thing, but it's not. And what Medicare is going around doing currently is, you know, finding out what device is the patient wearing if they're not wearing their PDAC approved appliance, even though it might be kind of pushing the limits on really the rules of what we provide for this PDAC appliance under DME. They're basically saying, we want our money back. So, I mean, I can't suggest enough for, if you think that you're doing the right thing by giving patients 2 devices at once and maybe having, you know, an ABM form, I don't know that that should be suggested anymore.
Dr. Federici, Dr. Tai, anything else to, Dr. Federici, I mean, you mentioned the workarounds. You were the one that broached the topic. Anything you want to add to Dr. Shanae or?
Well, I agree. If you're doing 2 at a time, you're purposefully, but I think if you give them a snore hook and have a legitimate trial within a couple months and you have this scan and you say it just didn't work, I wasn't able to comfortably wear it, but people who are never wearing them and you're just giving it a box, you know, you want to chart it that the patient's been dispensed that snore hook and tried it, sort of like a CPAP, you know, we'll give you 30 days and you can return it, you know, Medicare won't pay for it. So it's the same type of scenario with the snore hook. If you're going to do that, just make sure they try it and it's, documented that they were intolerant of it. And then you can go ahead and make the other one, right? And they can pay an upcharge or a scenario like that where, you're using that first round that was unsuccessful and the patient needs some form of therapy. So you're choosing to use that same scan, send it to a different lab and get a different type, and have the patient again with that ABN discussing the financials of it to make something that they're going to be compliant with and it's going to be effective.
Okay.
But the bigger question with that though is at what point is it okay for us to then change device style for the patient? Because there is no time limit. Do we follow like a 90-day trial period like they do with CPAP? So, I mean, there's some really gray areas with Medicare, and we bang our heads against the wall thinking we're doing everything accurately for them. And yet they can choose to do whatever they want and, say, no, you can't do it that way.
Yeah, there is no fixed time frame with them. You're correct. In the CPAP, while it's a nuisance thing, appliance is usually discomfort. And that's, I think, a difference because the CPAP doesn't physically harm. It's more of an acclimation thing. Usually with the appliance, there's either cheek biting or tooth pain or something fit-wise that the substandard typical appliance. Now, whether you're supposed to make a secondary PDAC one, that's the gray area, I think, right? You tried this one, but why wasn't your second one a PDAC approved? Maybe you should have tried the Herps Advanced Elite, like you said, with a liner in it, and maybe that would have been more comfortable. But there's a second lab bill, and again, there's nothing in the paperwork to say that you have to do two of the same, or so that you're right. There's so much gray area, and again, I would hope they would be more into doing what's right for the patient and working on other things versus barking up this particular tree. But this is why we have these roundtables.
Yeah, absolutely. And this hearty discussion is certainly an indicator that we need to have a full webinar on this topic in the future. So thank you for that. This isn't one of the devices featured here, but that's an EMA. We'll come back to that in a moment. But a question just came through from my friend, Dr. Ryan Askland, and he asked, he said he's been using the Serena Elevate devices a lot and seems to like it. Staining doesn't appear to be an issue. He wanted to know, before he keeps running with those for the appropriate patients, what your all's experience is. Dr. Ty, you want to share any experience you might have there?
I have not used it yet, but it is very intriguing. I can see how it can be something that people would like because it's thin, it's small. I love to hear that he's saying that there's not much staining on that particular device. I think it'd be nice because it doesn't have as much bulk on the side as well. It looks really good. I just have yet to try it. I wish I could help more.
Yeah. What about the rest of the panel? Experience with that device?
Same as Suzanne for me.
All right.
I've used several Serenas, but not Serena Elevate yet.
Okay.
I will tell you again, like a lot of these companies, they do work very well at making sure that you're picking the right appliance for the right patient.
Got it. What about EMAs, Dr. Shanae?
I can't comment. The only experience I have and the reason I don't lean towards them is again because the bands stretch rather quickly, rather frequently, and the patient has to change them quite a bit. But they are great in people who have a lot of TMJ pain. That's a wonderful device for that.
What about the two of you? Experiences with EMA? Any indications to use it in your practice?
For me, I don't use it often, but if I do, it's probably on a patient who really can't afford some of the other devices. So economically, just to try to help them in some way, then I will. If they have a really small mouth, if they don't have a very large range of motion, if they have a lot of angulation, it'll flex a little bit, but I don't use them often, but that's probably when I would use it.
Yeah, I just use them more like as a preview device to see if a patient can, number one, tolerate it, or like Suzanne said, there's a big outlet. I don't know if it's going to work for me, so I use it that way. Sometimes it's a quick device for somebody who just found out they're pregnant. they've been snoring prior. They're worried about the 50 pounds they're going to weight gain, and then they're going to have full-blown sleep apnea. And they have a developing fetus. And by the time they go through all the workflow, we're in the third trimester already. So it'll be something I do quick for somebody that way. But as my long-term durability, and like Nicole said, with the stretching of the straps, and is the patient have the ability to pull those off? You know, I know there's some firmer ones that'll last longer, but the patient might have difficulty taking them on or off. So very rare for me, just in those specific situations.
Okay, Dr. Federici, we'll continue to roll with you. What about the ProSomnus Evo device? It's been mentioned a few times tonight. When do you use it? When don't you use it? Which patients are presenting and you're going, that's the device I need?
Yeah, so I'm kind of like agnostic. When I'll look at the patient's mouth and evaluate their dexterity, all those things, and I'll literally pick out maybe 3 at the max 4 appliances and say, look, after seeing your mouth, I'm not going to expect you to pick between 20 here. But most of the patients, when I go over the pros and cons, choose this particular appliance because it's obviously, I show them it's milled out of a puck and there's 0 porosity, so you're just going to clean it with soap and water. It's digital. It's state-of-the-art technology in milling as far as precision. These things go right in. When I set the midline, it comes back that way. It's always right on where I have it. There are multiple trays, so if something happens to say to that herps or tap and it breaks, the whole appliance is out of commission for 2 weeks while it's getting repaired at the lab. Whereas this, they have multiple trays. There's 0.5 millimeter titrations extra. So all around, the patients really like this. They gravitate toward it. And I have all these appliances, and I tell them I have them all and I wear them all and I rotate through them. But I find that when you give them all the pros and cons, I say majority of the patients like this appliance. 12, 13 days, it's there, always on time. So really a great product.
What about yourself, Dr. Shanae? You mentioned it a couple times as well. Which patients do you use it for?
I mean, I think a lot of people know I use this quite frequently. I have to agree with everything Dr. Federici said. Again, when you show patients different devices, this one really appeals to them. And when you explain how there isn't any porosity, there's flexibility. It's not a bulky device. You know, they have plenty of room for the tongue. That's a big deal for, in my practice. And it's very customizable. I feel like I probably drive them crazy with all of my requests, but they are able to customize this in many ways. And I have a lot of patients who are missing quite a bit of teeth who do very well with these as well. So I would have to say this is probably, our primary device that we like to use.
It's surprising to hear you say that about patients that have some that are missing some teeth, because the material is fairly flexible. So I would imagine that it wouldn't be quite as retentive as you might need it to be, but it's pretty retentive is what I'm hearing.
Yeah. And I mean, they're just the one big thing I think that works really well is, with the patients who have a very large gag reflex. And I customize that as well. Just a little tip trick. Things that I do is maybe not cover the last molars, meaning like second molars. I might just do a rest seat on them, get that material away from the back side of the tongue, back side of the throat. And they really regain their confidence with it and feel reassured that they're going to be able to wear this overnight without having that horrible feeling of a gag sensation.
Got it. Dr. Ty, you have experience with this device?
I do. I've used it often as well. I will say this, that it's good, like I think Dr. Federici was saying earlier, for patients with manual dexterity issues, then it's easy. You kind of follow and you mix and match, so you know how to move the movement. There's no wrenching, there's no like trying to look at numbers. It's definitely easier for patients. I'm like you also, Dr. Federici, in the sense that I'll examine, and we'll see patients that are candidates for multiple devices, and I will show multiple devices. I do notice a lot of patients do gravitate towards it because it's looks like Invisalign, and they're used to Invisalign. They like the clear aligner. They feel like they have some mobility and range where they don't feel they're locked in. So they do like it. It's a great device, especially people who have just finished Invisalign. They seem like, well, this is the one I want. They do gravitate towards it. It's a really good device. I agree.
Gotcha. And then next we've got another device that's been mentioned a few times tonight, the SomnoMed Avant. Dr. Ty, I think you mentioned it a couple times specifically. When do you use it? What are the indications? What are the contraindications?
I mean, I really feel when it comes to SomnoMed's devices, my go-tos are always the Avant and the Hertz Advance Elite. And one of the biggest reasons is because its strength, its durability, the fact that it doesn't really stain. And the B-Flex liner is it's literally first time fit every time I put it in. It's first time fit. Patients are happy. They really like it. Great for bruxers. They're moving back and forth. I will say sometimes though that the band will start to stretch. And from what I'm understanding is they are working on that to try to get something where it's metal reinforced interiorly to kind of prevent that stretching. The other thing is just if you look at the mechanism, the propulsion mechanism, you want to be careful with people who have short clinical teeth on the posteriors or crowns or something, because it can kind of pull sometimes. But otherwise, it's a really good device. Patients seem to be very, very happy with it.
Yeah, so the soft liner, the soft liner is obviously for people who have brittle teeth or very expensive dentistry where they want maximum cushion combined with clenching, and they feel a hard material against them, against that restoration. It kind of makes them a little nervous. Yes, the strap does attach in the propulsion system anchored in the anterior. So if you have some mobility in these maxillary incisors, that might be a kind of a contraindication. Again, self-titration, that you can unsnap and slide the track, but again, the dexterity, and is the patient able to come in and have you do that? But overall, like I said, it gives them freedom. And we've had patients who have difficulty replicating a bite, or they deviate left one time, right another time, and it gives the dentist more freedom that if they can't get the bite right, they're not locked in, say, with a dorsal, that if it's wrong, they're going to create unilateral muscle issues, because it gives you a little bit of on that sliding on that track, that you can be less than perfect, let's say, and getting the bite translated to the lab and still get kind of away with it.
Got it. What about yourself, Dr. Shanae?
I have little experience with the Avant. Again, with my concern being that the strap was stretching out, but what I do like about it is it does have a nice design and has the interior stop and does have a lot of lateral play to it, which is nice.
Got
And
it.
it is small. It's a small device as well, so that always helps.
Yeah, you mentioned earlier, I think, Dr. Ty, that it's one that you prefer to use with patients that have smaller mouths. Yeah. Maybe not. Okay.
Oh yes, and I thought you said I did mention it. So yes, I did.
Yeah. Yeah.
Mhm.
Gotcha. Let's go to another question. This is one that there were various versions of this question that came through for this webinar, but which device leads to fewer dental side effects such as teeth movement or bite changes? I heard earlier, over the years, there's been concerns about devices with soft liners possibly having a higher likelihood of bite of tooth movement. Dr. Shanae, earlier you mentioned when we were talking about some devices, ball clasps. I know there's some concerns about that possibly opening up some contacts. So just maybe if you have insight as to what the data says, couple that with your own personal experience. Is there a device that leads or devices that lead to more, less? How can you mitigate this with device selection, Dr. Shanae?
There's a lot to say there, Jason.
Well, you've got 49 seconds.
45.
Okay, so I mean,
38.
again, with trying to be politically correct, I feel that our devices of today are giving us far less side effects than our devices of 12 years ago. I mean, our materials have changed dramatically. So obviously, for me personally, I feel that the Prosomnus EVO material does a very nice job of that with, and to put it simply, like if I have a patient who did Invisalign recently, the device I have the most confidence in is that EVO Prosomnus material, because I don't want to see any teeth shifting. On the flip side, like I talked about before, we used to use acrylic and ball clasps, but sometimes those it can be very helpful for people who have a lot of dental work, crowns, bridges, implants, stuff that isn't going to shift very well, and we need stability. So, but and again, my biggest deal is, and if you're going to use a nylon, I want to see a lot of attention to detail around each tooth shape with a nylon to try to mitigate shifting occurring in some of these nylon designs that used to just have like a band across the front teeth. We would see teeth shift in that type of design because it wasn't having a touch point on every tooth in a lot of areas of the tooth. That was just my experience.
Got it. Dr. Ty, what about yourself?
For me, dental side effects, there's definitely ways to possibly mitigate this. I do on my devices, I'll add distal wraps just to try to mitigate tooth movement the best I can. A lot of it, maybe it's just me, the way I talk to patients. I warn them I warn the patients ahead of time that this could happen. And I go over the benefits and effects of each treatment. And when they're coming in and they're saying, I'm not going to use the CPAP. I can't stand this, whatever that may be. I'm claustrophobic. It gives me PTSD. I can't have it on my face. And then let's say when I discuss oral appliance therapy, I'm like, this could happen. You could have tooth movement. Teeth are constantly shifting. That's the thing. That's why people with braces need retainers. If you don't have retainers, the teeth shift, correct? But can all the patients who had teeth shifting, can they still chew, smile, talk, eat, all those things? If they can't, the teeth are doing what they need to do. But then now you have this device, and now you are living, breathing, you have rested, you're, preventing heart attack and stroke. In the end, I kind of put that ahead of time to where if it does happen a little bit, the patients really aren't too upset. And if bite changes, I hammer into using an AM aligner. I know that's probably one of the questions later, but AM aligner, I definitely do think that it helps. I see that it helps patients who don't use it. I've seen bite changes occur, and it can happen.
Spoiler alert.
I know. But I really talk to them in detail in the beginning. And when it comes time, if any of this happens, they're usually not they're not upset. They really aren't. They're just like, okay, I said, we can go back to CPAP. We can go to Inspire. And they're saying, I don't want surgery. I don't want CPAP. You know what? That's okay. That's just what my experience has been. But yes, distal wraps help. The bite changes, I really like the AM aligner for that as well.
Wonderful. It's very useful. A quick reminder to everybody that because we get so many questions on tonight's topic, tonight's webinar is 75 minutes long. So we've got about 20 more minutes. And keep your questions coming. I see a lot of them coming through. Keep them coming. We'll try to get to them all. Before we dive back into those questions, I want to take a quick moment to remind everyone about the Transform Dental Sleep Symposium coming up in Scottsdale, January 31st and February 1st. It's our second year. The inaugural meeting earlier this year was very well received. So we've decided to do it again. We've got 20 plus of the most dynamic speakers in dental sleep medicine, from physicians to dentists to team members to world-class runners. We've got really the whole gamut of presenters this year, and they're going to focus exclusively on practical information and deliver actionable pieces of information so that you can go back to the practice and actually make things happen, change things for the better. Dr. Aaron Elliott will be there. Dr. Stacy Lehman and Alicia Crawford will be there talking about some really unique topics that will have an impact on attendees. And then a couple of tonight's presenters will be there as well. Dr. Federici will be there. Actually, quick update. If anybody's wondering how Dr. Carollo is doing, since I mentioned it earlier in the webinar, he's actually on the webinar tonight submitting comments. So he's fine. He's more than fine. But last year, after the meeting, there was a survey that all the attendees completed. And the topic that was most prevalent was a request that we share kind of the end-to-end patient journey in a practice. And when I started thinking about who best to present that, I was having some trouble. And I'm sorry to take us on a quick detour here, but I think this matters. I think it matters. One of the problems with dental sleep medicine education, I think, is that a dentist goes to a course and they hear from a presenter how they manage the patient workflow. The dentist goes back and tries to replicate that in their practice, and maybe it's not applicable. Maybe the dentist that lectured has a sleep-only practice, and you've got a restorative practice that's trying to get started with sleep. So when you try to replicate that, usually you'll fail, and then the dentist bails on dental sleep. So I thought it would be best indicated to bring together a panel of dentists, some of them with restorative practices, doing a lot of dental sleep in there, some of them with sleep-only practices. And that way you could hear this from multiple sources, kind of find out what resonates most with yourself, take, those tips, those techniques, and try to incorporate them. Another thing we heard from so many attendees at last year's symposium was that it was a very collegial environment, that all the speakers were willing to chat afterwards, have conversations, share their best practices, and really help these dentists, help them out by sharing their insights and giving them the nudges that they need. So we've got that. That'll be Dr. Federici, Dr. Max Kerr, and Dr. Carollo. And then we've got this other lecture that's one of, more than a dozen that'll be going on. But this one I think will be incredibly insightful. Coordinating with Inspire providers for more oral appliance referrals. Dr. Shanae, you tell them, what is that lecture about?
I think it's going to be a really cool lecture, and we actually are going to show a few of our patients that we're seeing right now who must have combination oral appliance along with Inspire, where the two are not enough for the patient individually, but you put them together and you really get an excellent outcome. And we're seeing more and more of this. And it's not just about Inspire, but how much we must coordinate with especially our sleep, ear, nose, and throat doctors to give the best outcomes for these patients. And everything we do is a multi-level approach. Dr. Seuss and I have been working together for 15 years. And, you have to think outside the box. You have to get creative. The dental sleep and sleep medicine is not a black and white field, as we all know. And so finding the best fit for those patients and combination therapy can really give us some wonderful outcomes for these patients who think that they have no options. So I say stay tuned. We have some exciting things to share, and it's going to be great.
Yeah, really looking forward to that. And Dr. Ty, you were at the meeting last year, and you even got one of the special invites to the after party. For everybody
Yes.
that's here, is the meeting worth coming to? Useful, good use of your scarce resources?
100%. What I love about your meeting is that it is a lot of real world aspects that I feel like anybody who's doing dental sleep medicine needs to know. A lot of business that can help, because you can make an appliance, you can make it so perfectly and so great for the patient, but if you have no patients coming in and you don't know how to treat that patient, you don't know how to get that patient to go through with treatment, then it doesn't matter. We're helping no one, right? And so I think there was a lot of real world applications. I feel like there was a lot of medical discussions as well. And so it's really good. And I saw the lineup that you have. I'm super excited about this event coming up in January. So it'll be great.
And Dr. Ty, I'm putting you on the spot here.
Sure.
Are you willing to speak in 2026?
Absolutely. I'd be more than happy to.
Oh, nice.
Uh-oh.
Excellent. We've already started lining up speakers for 2026. Thank you, Dr.
Okay.
Ty. So anyone that's not registered, actually, one more thing, Elias, you want to bounce back real quick. Anyone that's not registered yet, I'm sorry to toot our own horn here, but I think this is important. We sold out. The meeting was sold out last year. I mean, you all can attest to that. There were several hundred people there. The meeting sold out last year. Right now, today, we have 4 times the number of registrations we had on this date last year. So that means we're going to sell out far in advance this year. So if you're thinking, oh, I'll see what I've got going on in January, maybe I'll go, maybe I won't, it will be sold out. Additionally, the room block, we have the entire hotel blocked. But about 2/3 of those rooms are already sold out. So this isn't a matter of maybe you'll register later and get a hotel later. And you'll miss the room block rate, which saves you over $200 each night. No, there will be no room at the inn. You're going to have to stay. We've got a beautiful resort venue. It's brand new. You won't be able to stay there. You're going to have to stay 4 miles away at a Holiday Inn Express or something like Dr. Shanae almost had to last year. So snooze, you lose. If you're going to come, register now. And just to make it a little sweeter for you, if you register by Friday, use the code JT100 and you'll save $100 on tuition. All right, let's get back into these questions. I'm tired of the self-promotion. I feel a little ick. So, Dr. Ty, you tried to steal the thunder earlier about morning aligners, but there are a lot of questions about this too. Do they really work? And what do you do? And this is a question that's actually come through a couple times tonight. What do you do if a posterior open bite develops, as a result of appliance use? You stole the thunder, Dr. Ty. I'll give you back the baton. Run with it. You said they work.
I do believe so. For
you
sure.
use them for every patient. And what do you do if there is bite change?
I do it for every patient. I literally do. I do it for every single patient because I feel like that will help them and it'll kind of ease their mind. And if they don't use it and the bite changes, then I hate to say it, but I said, do you remember we talked about it? And again, going to discussion with patients, it's not just, oh, here's an aligner. Okay, you got to do this. No, you need to talk about it and slow it down and pause and explain to them and show them how to use it. You don't just make it and then put it in their box. You make it and you have them put it in, you have them bite on it, you have them exercise, know how to put it in and do it well. When they do it, I don't see bite changes occurring that often. Now I do tell them that it can still occur, sure, but if it does, and knock on wood, and if it changes, it might be minor, but most of my patients, if they have any type of bite change, I literally go back to going over my clinical notes and reading what brought them here in the first place. What was their success? What is it that they deem success? What do they want to see accomplished? And many of my patients say, I'm sleeping better. I feel so much better. I'm back in room with my husband. I said, because the other option is going back to CPAP or doing something else or surgery or Inspire. And they'll say no, and they'll go back to just having what they have. And it could be minor bite change. Now, if it's minor, then you might be able to kind of get them back if it's minor. But when you have a posterior open bite, that's difficult. And I'm hoping Dr. Federici and Dr. Shanae can kind of help with this because I don't see that too often. I would kind of lend to them to kind of answer that last question.
Okay.
Nicole, you can go first.
Me first?
Yeah.
Dave, go ahead, Nicole. Yeah.
So again, it's all dependent on the patient and what's the biggest concern to the patient. So when I have a patient who presents with a posterior open bite, who is concerned about it, sometimes, guess what? Sometimes it happens with our patients that do their morning aligner every single day. But what happens over time sometimes is that they're not fully biting into the morning aligner. So when we fabricate our morning aligners, what we do personally in my practice now is we fabricate it on the maxillary anterior teeth, and the patient bites into it, and we mold the material so that we're really trying to prevent any type of forward movement with those mandibular with the mandible. So we're blocking that area. You know, for years as I was trained, we made them on the lower. And but what would happen over time, some people thought they were biting into it when actually they weren't fully engaging their occlusion in the back. So, you know, again, this evolves, and with experience, you get more experience and you just learn what to do and what not to do. Okay, so I have a patient who shows up with a posterior open bite. We have a frank discussion, you know, and just like Suzanne says, is what are our priorities? Is this a big concern to you? Is it not? Obviously, I'm going to try and improve that posterior open bite chair side. I'll just lay them back in the chair for 15 to 20 minutes, put a light cotton roll in the front, try to deprogram their muscles a little bit, and literally try to guide the jaw back and make a new morning aligner, and then plan to see them in about 8 or 9 weeks, advise them to do the physical therapy stretches we give them, advise them to do their new morning realignment bite, you know, whether it be in the morning or afternoon or even in the evening, wherever they can engage that morning aligner best. And then I plan to see them in like probably about 9 months, and then kind of repeat the process in the office and see if I can then sort of guide the jaw back even further. And sometimes this is successful. And we have the discussion, if you want to discontinue use of your oral appliance to allow your jaw to kind of come back naturally, we might need to go back to CPAP for a period of time and then start from scratch. Most patients do not want to go back to CPAP, and they do not want to go to bed without their oral appliance at that point. So again, they are well aware from the beginning, because you have those discussions with them before they start oral appliance therapy, that is a risk factor that might potentially happen with them, especially if they're not compliant with their morning aligners.
Mm-hmm. What about
Yeah.
you, Dave?
To piggyback on all that, I mean, we just don't know how a muscle is going to respond after 7 hours, and we expect 5 to 10 minutes to recover. I mean, every muscle is stretched. They're not like rubber bands. They don't come right back. And if over time they come back 95% of the way they were stretched, there's going to be a 5% change. There's force vectors. The more you advance, what if somebody needs to be +5 for their airway to be open properly? The side effect is we could have a greater chance the muscle is not going to rebound. So I do some of the things you ladies talked about. I also give them their exercises the day of scan. So the 2 weeks while they're waiting for the appliance, they'll be getting their muscles prepped for it. A lot of times I'll have them take it out in the morning when they're in bed. And like you said, Nicole, when they're laying back already, let the fluid flow relax. Sometimes immediately upon removal of the appliance, they're not ready to be rushed back that great amount of millimeters. So we give them 5 or 10 minutes. And if they can lay in bed back, and they can use, say, the handle of the AM repositioner to bite on that, and that forces that fluid out, then when they get up, they can wear their AM repositioner. We have the physical thinking man's pose. We tell the patients based on your schedule, if you have to get out the door quick, we expect you to get a hot shower, massage the muscles, rub your tongue from the front of your palate to the back of your palate. And if you try that, you'll feel that pulling the muscle back. Get that AM repositioner in there. Just don't eat until that jaw is recovered, because a time here and there won't be a difference. But if you consistently don't use it and you eat on it in an improper occlusion, it's going to lead to these changes. And like somebody said, you can never confirm. They can say, I wear it every day for 15 minutes. They have to live with that decision that they're lying to us. And they'll know deep down that it was their issue of not wearing it or not being compliant with it that led to this. But the ultimate line is, I'd rather have a little bit of an open bite than be in the grave 10 years earlier.
Sure, sure. Next question. We've got to make this one really quick. This isn't a discussion. This is a one-word answer. Nope, that's not it. That's it. Anecdotally, Do your patients feel any one device is more comfortable than the others? What device, you wear one yourself, you mentioned, Dave, whatever. Which is the most comfortable device? Dave?
I mean, they're all
No,
decently comfortable.
no. One
So
answer.
I'll say the Evo because it's the
Okay.
smallest. Comfort for me, smallest comfortable.
All right. Dr. Ty.
I'll say the Avant.
Okay. Dr. Shanae.
Evo Select.
All right. Next question. You can expound on this next one. This is something I've run into a million times. I've got strong feelings about, but I want to hear, people want to hear yours, your insights. Patient's been wearing a device, won't wear it. I'm wearing a Herbst. Oh, it's rubbing on my cheeks. I don't like it. Do you make them another device? And if so, what do? Do you just eat the cost? Do you charge for it? How does that work in your practice, Dr. Shanae?
I do what's right for the patient. But you said, if they're wearing a Herbst, again, if it's a person who has to have a PDAC approved appliance, I have that discussion with them beforehand, and this is what your insurance will only allow us to do. If you find that this is not the device for you, then we can offer you an alternative device. In that situation, I am going to charge the patient because our hands are tied. If it's a situation where I've picked the device for the patient, they're not having success, to heck with it. I make them a new one. That's not on them. If it was something that's in my hands that I felt I could control better, I take care of the patient. It's what we're supposed to do.
How does that differ from how either of you might manage that situation?
Again, when I have the device, I find what is compatible for the patient, what they could wear. And I give them the choices. It's usually not just one. It's usually not just one. So I'll have choices. And if they pick it, then that's what they chose. Now they ask the questions, well, is this metal on the side of my mouth going to bother me? I said it could, but then my verbiage is, well, how many people do you know have had braces and had metal brackets everywhere and with wires, and they're able to wear it? I said, a lot of it is some kind of mindset on what they're feeling. And of course, if there's ways, I will try my best to make this appliance work the best it can, whether it's having to use, whatever it could be. It could be just adjusting within the appliance. It could be having wax around it, even though the wax doesn't stay long, but just something for them to feel like it's working. It's rare, but if it does happen, they just absolutely hate it. Well, in the beginning, I also say there's no guarantees. I always tell myself there's no guarantees in health and medical, but what I do guarantee is that I will do everything to make it as successful for you as possible, but you just need to communicate with me. If you communicate with me, I can help. If you can't, then, what are we going to do? So then if that happens, and it hasn't happened very often, but if they really want another device, because remember, they chose the first one, given the ones that I'm allowing, then they'll have to pay like a lab fee if they want a second one.
Got it. Something that each of you have touched on tonight, in different ways, is the importance of communication. Setting the expectation on the front end, letting people know, what to expect, and that both means, what will happen and what may or may not happen. But setting those expectations on the front end really helps to clarify any ambiguity or eliminate or at best mitigate any possibility of misunderstandings later on. So while I don't think that was something that we necessarily underscored until just now, I hope that everyone takes that away, that communication is key.
Well, Jay, you're right. And I think if you explain the pros and cons of every device and say, which one do you like? It gives them a choice. And the last thing you want is, hey, I wanted that one, but you put me in that one. Then the paths diverge. And like you said, issues become magnified. So when they have skin in the game and they pick and say, you know what, I think I like that one, they're going to take ownership of that decision. And I've literally had maybe on one hand ever have to run into this situation because I did a thorough job in explaining to them up front, like Suzanne said, pros and cons, from cleaning to maintenance costs to titration to visits to this and that. And then they're well informed to the point where, okay, I think in my mind, because they may say, what's comfortable? What's the most comfortable? Well, comfortable for me might be a soft liner, but comfortable for patient B doesn't gag them. You know, so comfort has different definitions. So again, when you
Great
try to
point.
define that for the patient, you define what comfort is, and then you make a priority list, what's most important, and then all of a sudden they take ownership.
Absolutely. We're about to wrap here in a second. You've got 15 seconds each. If you want to impart one thing on everybody that's on tonight about appliance selection, whatever that means to you, what would you share with them? Dr. Dave?
I'll just say get as many samples as you can. Try as many appliances as you can because you want to experience what your patient's going to experience. And then you can give them some feedback. And what I do in my office is I have a bunch of them there and I show them what it's like in my mouth and how it works. And that gives them like a real good visual feedback. But you'll get experience as you try different ones and get the feedback through different appliances. So just hang in there and you'll find your favorites.
Sound advice. Dr. Ty, 15 seconds. Parting words for everybody.
I would say definitely if you're new to this, utilize your labs too. If you're not sure, you can send your scans in, ask the labs, see which one they think could be best. I can't stress enough communication. You will find yourself in less hot water if you communicate and they know that you care. They know that you are knowledgeable and that you care. And then in the end, when they choose, then they just won't be as upset. But the devices, they work. So
Yes.
It's not necessarily each device, it's using a device.
Dr. Shanae?
This is what comes to mind for me. I think we learn always from the things we don't do well or what we consider failures than what we do great at every single day. And so you gotta experience different appliances. You gotta try them yourselves and see what they feel like in your mouth and what patients might be experiencing. And maybe you did a particular device on a patient and it just didn't go well. Well, you're going to learn from that. And then you're going to see that kind of a similarity in another patient in the future and go, oh, well, I don't want to do X appliance because I had that similar experience based on what the complications are of that patient's mouth. You got to get out there. Don't be afraid. Just try it. There's going to be times where you do awesome. And there's going to be times where you're like, I don't think I'm benefiting this patient whatsoever. It's okay. You learn from all those experiences. Just go for it. You're improving everybody's lives greatly. Just do it.
Love it. Everybody that's here, we hope you'll join us on our next webinar. We're going to take a little bit of time off. Our next one is October 22nd. It's about medical billing, a topic that no one cares about. That was snark and sarcasm. Everyone cares about getting paid. From K codes to VA contracts, to get your dental, sleep, medical billing questions answered. We'll be with several of the team over at Pristine Medical Billing. I would say I refer to Randy Kern, one of the speakers, as the oracle of medical billing. I think he knows everything about medical billing, or nearly everything, maybe everything. And that'll be a good one. So register. It's going to be on Tuesday, October 22nd, 7 p.m. Central.
I put the link in. Sorry, Jason.
Yeah, thanks for putting the link in, Elias, down in the chat. And then want to remind everyone, register for the symposium. Use the code JT100. You can register at tdssymposium.com. And one last thing about the symposium is if you want to take a deep dive on a topic like medical billing, on the day before the symposium, so Thursday, January 30th, we're going to have a 6-hour deep dive workshop on medical billing presented by Randy Curran and several of the team members from over there at Pristine. But it's limited. That workshop is limited to only 35 attendees. There's quite a few signed up already. You've got to register for the symposium and then register for this as well. There's a question coming in, something about this actually. Elias, I don't see that, so I'm going to ask you to jump in a sec. But you can register for this. It's limited to 35. So intimate group setting. It'll be fantastic. Encourage you to sign up for that.
I'll just read it real quick. It says, I'm planning to attend the Transform Dental Sleep symposium. Is the insurance, Eric, you could see it?
Yeah. Will this be beneficial for Canadian attendees? I don't know the answer to that. Certainly, we can put that person in touch with Randy. So Canadian dentist that asked that question, we've got your contact information, and we'll get that information and circle back with you. With that said, once again, just like the way we started this out, I want to say thank you to all of you. There's so many other things you'd be doing tonight. Being here, listening in, asking questions, engaging is a testament to how committed you are to learning and growing and helping more patients. We hope that there was some information tonight that you find useful, and of greatest importance is that you then take that and put it into action. You know, education without action is kind of futile. So put this into practice. Dr. Federici, Dr. Ty, Dr. Shanae, thank you so much for doing this. I know how busy your schedules are, especially with everything you've got coming up, Dr. Shanae. Thank you. Dr. Ty, congratulations on the diplomate certification. Dr. Carollo, I know you're out there and you can hear us. Thanks for joining us tonight, and we'll get you on a webinar in the future. Dr. Federici, thank you for all your support, all the education that you share, your commitment to dental sleep. It truly, it's laudable. Thank you all. I'll see you all in Scottsdale. Hope to see many of you out there in Scottsdale, and have a great evening, everyone.
Bye.
Bye. Thank you.
Thank you.
Thank you.
Good night.